Well, hello. I'm Jill Holt with Mountain Pacific, and I want to welcome you to we just counted it up, and this is our 18th session for It's Worth a Shot. So today we have the privilege of a guest speaker and then hearing from one of our own teammates. And so let me just begin with the introduction of our first speaker. Our first speaker will be visiting with us about the power of language to create culture and PPE. And then our second session will be with Marcy Gallagher, and she will be visiting with us about PPE fatigue. What I'd like to do is just read a little bit of the bio for Carmen Bowman, our first speaker. Carmen Bowman is a consultant, a trainer, author, and owner of EDU Catering Education for Compliance and Culture Change, turning her former role of regulator into educator. Carmen was a Colorado State surveyor for 9 years, a policy analyst with the CMS Division of Nursing Homes, where she taught the National Basic Surveyor course. As a contractor to CMS, Carmen co-developed the Artifacts of Culture Change and facilitated the 2 national Creating Homes symposiums regarding culture change and the environment, and food and dining. Carmen has a master's degree in healthcare systems. She co-founded the Colorado Culture Change Coalition, has authored 8 culture change workbooks, hosts the monthly talk show Conversations in Culture Change with Carmen for 12 years, and co-authored the white paper, The Power of Language to Change Culture. Carmen is a co-editor of the international journal Activities, Adaptations, and Aging, Purposeful and Dignified Living for Older Adults. She has taught culture change on several ECHOs and Wyoming Center of Aging, and holds a 3-year grant supporting the Wyoming Culture Change Coalition and awareness around the state with free monthly webinars, annual workshops, and coaching with 5 nursing homes per year. Carmen teaches how to shift from a traditional institutional medical care focus to the life people are living. Good care should be a given, while the focus is intentionally on the life people are living. So with that, Carmen, the floor is yours.
Thank you. I'll take the next slide, please. And we're going to zoom through some good stuff, everyone. Next slide, please. Looks like they would love to know what your next webinar topics you would like them to be in the chat, please. And I'll take the next slide, please. So I want to thank Mountain Pacific. Guess what? We have a Culture Change Coalition and a 3-year grant in Wyoming because of Mountain Pacific. A few years ago, Pat Fritz found a little bit of money, and we did a culture change tour through Wyoming, which has led to what's going on right now. And I know some of you are from different states. You could make this happen in your states as well. Next slide, please. And so what that means, everyone, is a bit like Jill just said, this 3-year grant, we called it Affecting Resident-Directed Living and Team Member Retention. So I'm helping to establish a coalition for culture change. I'm coaching 5 nursing homes per year, and the free monthly webinars, as well as an annual conference. Next slide, please. And I just want you all to be aware that the next annual conference is actually 5 free workshops throughout the state. August 1 through 5, we're going to see Mission at Castle Rock. It is a Eden Alternative Home. Morning Star is also an Eden Alternative Home. Greenhouse Living, our greenhouse small home, nursing homes. And then Life Care of Casper and Life Care Cheyenne. Just want to get the word out. Contact me if you need to know more. And the next slide, please. And so today I'd love to just kind of raise the issue of language. This is a free resource if you want to know more. The Power of Language to Create Culture. I got to co-author this white paper. It's free. It helped me learn a lot. And I'd love to ask you all, what has the pandemic, what has isolation, quarantine, wearing masks and other PPE done to our culture and to our language? If you could start sharing the chat box while I talk, that'd be great. And I'll take the next slide, please. I'd like to show you just a few things that we have time for today. Learning from the disability community, they brought to our attention person first language. So if you want to err on the side of anything, always err on the side of the person. And so you put the person before any condition or disability or diagnosis. And you describe the person first, you don't describe the illness first. And so that helps us to learn, as Jill says sometimes, think of it as this bucket. You want to describe what a person has, not kind of bring it and pull it into who they are. And so keeping that separate. And so look at this. We often say diabetic. We've all said diabetic. It sounds right to say diabetic, doesn't it? But guess what? That's not person first. That's a label. A lot of things with IC at the end are labels. A person with diabetes is person first. And check this out. How many of you are myopic? I see some of you right now. Some of you are myopic. Did you know that? But we don't say that, do we? We just refer to wearing our glasses. I need my glasses. Isn't that interesting? I'll take the next slide, please. So let that be our guide, everyone. We don't have to say myopic, and we don't have to say diabetic, and we don't have to say paraplegic. That's someone who has paraplegia. And we don't have to say the dementia patients. Those are people who have dementia. And so people are not a disease. People are not a problem. We are humans with needs and require help and assistance. Isn't that beautiful? I'll take the next slide, please. And look at this, look at this. So what do you prefer to be called? Handicapped, disabled, or physically challenged? And the gentleman said Joe would be fine. And look at this, the most appropriate label is usually the one people's parents have given them. So what is the only label any of us ever need to use, ever? The person's name. No more labels, everyone. I'll take the next slide, please. No more labels. In fact, did you know CMS is onto this? At one of the resident rights tags, 550, under respect and dignity, we are to avoid the use of labels for residents, labeling people such as feeders, isn't that lovely, and walkers. Now, those are only two of many. They could have put pages, but they didn't have space, right? So feeder is a label, everyone. We don't have to label people that. Nope, that's Joe who needs help to eat. And that's someone who walks. Yay, how wonderful. And Joe can walk. Wow, right? We don't have to label it. Next slide, please. There are so many labels. In fact, I really don't have time. If you think of all the labels that we run into, just try to remember and catch yourself, that's a label. And the only label needed is their name. And then what I have seen during, I don't know if it's because of COVID, maybe everyone, we're slipping back to a lot of medical language, and I hear the word patient a lot. So what is a patient? Actually, a patient really is in a passive position. You receive care. You're usually in a clinic or with your doctor or in the hospital. And to be a patient is not a person. It's someone who has an illness. And we don't tend to see a patient as an individual. They're a person, not a patient, one of our Wyoming ombudsmen has said. And one of your own, Mark Marabella from Hawaii, says, I have long believed there is a disconnect between people and care. A patient is in a passive position. Things are done to them. And guess what? That's why CMS chose the word resident to begin with. So of all things, everyone, at least use resident before patient. And then we've moved on from resident. We tend to use stronger words, the person, the individual. Some teams have even gone, communities have chosen the word neighbor. Isn't that interesting? The people who live there are neighbors to one another. They really are. And there's a test of our humanity, everyone, in a sense. Are you going to keep calling them patient because you're the nurse and it looks like the professional clinical thing to do? Or would you morph over to actually calling them neighbors because that's what they are to one another? And it's so much softer and so much more normal. Next slide, please. And look at this, you know, even person-centered care. Did you know that when CMS printed person-centered care in the 2016 new regs, it was already outdated. Isn't that sad? The culture change movement had already switched over to person-directed. It's stronger. Just ponder that for a minute, guys. Person-centered is good, but person-directed is even stronger, and that's what we want to move towards. And then guess what? Where I now live in Indiana, there's this big billboard, probably for a hospital, that says you-centered care. And I figured, oh my gosh, that's what we should do. We should switch it over and keep following with me. It would become you-directed care. That could be fun when you're referring to care. Next slide, please, because we have an issue. Let's see, if you could do the next click, please. I hope, yep, watch this, everyone. In your states, if someone moves out of their home when they're older and can't, keep up with the house, they tend to move to what? What's it called? Independent what? Independent living. And then they need more assistance. Next click, please. And what's it called? Assisted what? Assisted living. And then they need more what? Care. And what's it called? Next click, please. Watch this. Where did the living go? Do you see? Even the word living disappeared when it all became about care. And I do believe that is part of the problem. I'll take the next clip, please. We all can change our language. It costs no money. You can decide to say certain words from now on. You can decide to not say certain words from now on. And so some of the lingo could be resident directed living, resident directed life. Next clip, please. A leader in our field also brings up, it's really self-directed. We want to self-direct our lives as long as we live. You and I are self-directing our lives right now. And then you and I working in this field have the privilege to give that to people, to have a self-directed life. And I don't mean to label it. It's just ideas you can use instead when you're trying to figure out what to say. My message would just simply be, I challenge you, I invite you, I beg you to talk more about the life that the people are living who live there than the care that they're receiving and that you are giving. You see, care has gotten all the attention and life and living has not. And we need to flip that from language to reality. I'll take the next slide, please. And so a challenge I've realized, everyone, is to challenge yourself to look through the lens of, this is someone's house, this is someone's home, this is a community more than a facility. This is a person, this is an individual instead of a patient. No. So use home and community or the name of the place. Just keep calling it St. John's. Avoid the word facility. The word facility is not home. Okay, none of us live in facilities. And instead of unit or ward or station or floor, we're moving over to instead neighborhoods. Oh, it's so normal. Department is very institutional. Try team, it's lovely. There's power in language. See, you want team to be spread around. Let's be a team. It does more for your culture than department. That actually hurts the culture because it keeps perpetuating the departmental silos. And that's not my job, and that's not my resident, and that is the mark of an institution. We're also trying to get rid of rounding, everyone. A lot of us use rounding that is from the hospital or the farm, to be honest. And it's an opportunity for us to reject medical language. I challenge you, I invite you. People check in with other people. Think equal. You're adults, they're adults. You check in with, or you do check-ins. We don't round. And intervention is used a lot in this business. It's a harsh word. If you are outside of the long-term care world, what is really an intervention? It's a harsh, big, bad thing. You're having to intervene with someone, or police are intervening with something bad. And so that's not what we mean. I think we've always meant, everyone, approach, because the approaches you take for Sally are different than the approaches you take with Joe. And even better yet, I would call it individualized approaches, because why? There's power in language. You're reminding, oh yeah, it's supposed to be individualized. Isn't that great? Next slide, please. I think I'm almost done. 2 more slides. Look at this. Some pandemic kind of language I want to draw out. I've learned this recently. Look at this from someone else smarter than me. Lori Porter is in charge of the National Association of Healthcare Assistants, CNAs. And she says, let's call it care force instead of workforce. Brilliant. Do it. Try it. Come on. And look at this. Leaders in the culture change movement right away were saying, don't call it social distancing. No, what we really mean is physical distancing. We got to hang on to the social. Let's not even use it in the language, everyone. And then lockdown just kills me when everyone says it. We don't have to say that. There's so many words that are military-like that I didn't even have time to go into. Just refer to if you have to quarantine or if someone is on isolation. Next slide, please. And so I want to invite all of you to consider yourselves proactive preventionists. You have the superpower of language, and you have a superpower to be proactive. And so I'm maybe treading on some, I don't know, it doesn't matter. A lot of you represent coffee on the line, right? And I learned this from someone in Minnesota, Kelly O'Neill, led the coffee, you know, the new coffee. She helped design it. And she said, Carmen, just don't call it a program. Why? Because program, that word, everyone, is the mark of an institution, and we tend to check out. And what I mean is, if you talk about the coffee program, many of us are going to think, oh, that's the administrator's program and not mine. Or if you talk about your infection control program, guess what? We check out, oh, that's the infection preventionist program, not mine. And so there's power in dropping it. Isn't that great? So you talk about infection control, and who should do that? Everyone. We should all be infection preventionists. And you drop program from QAPI, who should be in charge of quality assurance, performance improvement? Everybody. Next slide, please. Isn't that cool? And so my takeaway is, be cognizant of this institution speak, this institutional language. Please be proactive. Catch yourself on it. Be a role model. Catch yourself in front of people out loud. That'll help change your culture. Agree to talk about it. Remind each other. Have fun. Maybe have a word of the month. Talk about it. What does discharge really mean? Oh, there's a fun one. And how about get a culture change coalition in your state? And if nothing else, emphasize the life people are living even more than the care that you're giving and the care they're receiving. Just move towards normal home life. Thank you so much.
Carmen, thank you. That was a lot to take in and a lot to absorb. And fortunately, we have your slides. We'll post those on the website just so we can refer back to some of that language that you gave us. I love those tips that you provided. Thank you.
Sorry, got to go. Thanks, everyone. Take care.
All right. Thank you, Carmen. So moving on to the second part of our presentation today, Marcy Gallagher.
Thanks, Jill. So let's talk about PPE fatigue. Next slide, Mary. And we are going to start out with a quick poll. Mary, if you could just pull up that polling question. So just as a general estimate, what do you think the rate of PPE compliance is at your facility? So while we're populating that poll, PPE fatigue is definitely real. You know, we are just all tired, right? We are numb to the news about COVID. So when we talk to nursing homes, many feel their outbreaks are possibly linked to a lapse in their PPE compliance. On the flip side of that, many homes that have prevented outbreaks or have quickly contained an outbreak from spreading credit good PPE compliance. And with community transmission rates on the rise, it's really important to continue to be vigilant. So Mary, can you go ahead and reveal the results of that poll? So that's good. We got a fair amount of folks feeling that it's, you know, getting close to that 75 to 100% range. And not surprising that, you know, not everybody's at 100%. So thank you. Okay, next slide, Mary. Just a reminder, the CDC still recommends source control in healthcare settings. Next slide. I like this fact sheet that was on the APIC website, and APIC is the Association for Professionals in Infection Prevention and Epidemiology. And this is actually a fact sheet you can print out and post just as a reminder to help preventing PPE fatigue using a real approach. So remind, educate, audit, and lead. Next slide. So here are some ideas that we have learned from you all out in the field, just talking with other facilities, what has helped them with PPE fatigue. So masking, comfort, making sure your PPE is fitting appropriately and doesn't interfere with getting your job done. We've seen folks use fun colored masks and stickers. We had one nursing home that ordered patches for the inside of the mask to preserve lipstick. That was one request from staff saying, who wore lipstick, and even though you can't see it when they're wearing their mask, it was important to them to maybe not have that come off on the inside of the mask. So that helped them with their PPE compliance. And we've also heard from facilities who have masks with a clear front. So residents who are hard of hearing or have dementia can see the mouth of the staff person. Eye protection, we have received feedback that you can order safety prescriptions online from Walmart and somewhere called Zenni Optical, Z-E-N-N-I. And also, one facility had mentioned that they had purchased some side shields for glasses or anti-fog safety glasses, and that helped increase their compliance with their eye protection. Next slide, Mary. So other things like take breaks, just make sure you're reminding staff to take breaks. Assign a battle buddy. This is really something that was created by the U.S. Army, and the battle buddy system focused on ensuring soldiers had someone to watch their back, but the concept can be used to shore up each other's PPE use. So for this to work, you both have to commit to the other that you will speak up and not let your buddy expose themselves unnecessarily. So commit to being an example setter, starts with senior leaders, and use team meetings and huddles, not only as reminders, but to also solicit feedback. We had one infection preventionist tell us that she visited with her staff about PPE compliance and what were the barriers they brought up that she could remove her PPE while she's in her office. And so she really took that into consideration and felt that to be credible and to lead by example, that she was going to keep her mask on at all times, even while she was in her office. And enlist champions. This doesn't have to fall on just the infection preventionists or the DON. Maybe there is a, another CNA or staff member who can help be a champion and promoting PPE compliance. Audits, be creative. We had one facility who, whoever was doing the auditing walked around with a bag of candy. And if you were compliant with your PPE, you received a piece of chocolate. And if you weren't, you received a Sour Patch Kid or a sour candy. And tell your facility story. Post and showcase your audit results so everyone can see. Next slide. So let's hear from you. What is your team doing to help combat PPE fatigue? If you guys can just use the chat box and just tell us what you're doing. And I see there was a question, does CDC recommend either facials or goggles only? And Jesse did indicate that CDC does not recommend a specific type, just the appropriate eye protection to wrap around the side of the face. Thanks, Jesse. Is anyone doing anything kind of out of the box or something that's worked to help with PPE fatigue? Facility competition between departments. Excellent. Thanks, Cindy. Okay, well,
Hey, Marcy, this is Miranda. Just to build off, when you're talking about one of the people went around with a bag of candy and a bag of Sour Patch Kids. So I know most people have seen Harry Potter, and they have these jelly beans where they have different flavors. Sometimes they're popcorn, sometimes they're like dirt or worm, or, they have a crazy, variety of colors. So another variation off of that is that would be something fun to, because you pick one and then eat it and try and figure out what it tastes like. But instead of just being a Sour Patch Kid, it's still a fun game where people would want to join in, but, you know, it's a relevant of, you know, the Harry Potter world, and, you know, just to make it more fun and less punishing, I guess is what I would say. But also, you know, when you pick a really bad flavor, you're going to remember that you ate dirt that one time, and that you need to, you know, pay attention about your mask, or something that tasted like, you know, a booger or something, you know, just something fun that way.
Great point. Definitely can expand on that. So thanks, Miranda.
And you can order those online, by the way, just, you know, if you're thinking of ways to get them, you can order them online, like through Amazon or whatever.
Okay. Awesome. All right, how about the next slide, which just is just recapping some of our resources. There is that couple of fact sheets from APIC, some audit tools, the product links for some of those eye shields. And next slide. So our next session, we will be back on track next Wednesday, May 25th. Please complete the evaluation link that's in the chat. And did anybody have any questions? All right, well, if not, we'll give you a few minutes back in your day and hopefully see everyone next week. Thanks so much for attending today.